and welcome to Alzheimer's Speaks Radio. I'm your host, Lori LeBay, and I'm so excited that you're joining us today. We are going to have a fascinating conversation as usual as we learn from people all around the world at all ages and stages of life. Stay tuned as we shift our dementia care from crisis to comfort.
Here we go. What you think about, you will bring about dementia change. We will.
So getting back to my question on caregivers, do they have to be on Medicare or Medicaid?
They do not have to be on either of Medicare or Medicaid. The very first thing that we do when a patient asks us to enroll in the program is, first we ask some questions. Let's find out about your insurance, because if you're not traditional Medicare, you don't qualify. But then the next thing that we are required to do is what's called a comprehensive assessment. That's one of these guide care delivery services that we're required to provide. That's one of the 9. And that comprehensive assessment is an assessment of both the patient and the caregiver. And so we work with the patient and the caregiver to assess the level that they're at, which ultimately then goes to Medicare, and then Medicare makes the decision: is this patient qualified, and does the caregiver qualify?
So basically, the program is under the patient's Medicare.
Correct.
Insurance.
Yeah.
Okay. And so the caregiver doesn't have to qualify. What about all the people that don't have a caregiver, that are, just swimming this thing upstream by themselves?
Well, so the program is actually designed to cover them as well. Obviously, it's much harder for that patient as the disease progresses, because the primary method of interaction, I said this early on, the proof, the value of virtual care was proven in these National Institute of Health studies. And so the vast majority of the care that's being delivered is virtual in nature. And obviously, while we can use video, we can use regular telephone, as we talked earlier, that ability to comprehend as the disease progresses gets harder and harder. But there are 5 different tiers, and we won't get into the details, but there are 5 different tiers of the way that patients and the caregivers are classified. 3 of those are for patients with caregivers, and there are two classifications for patients who have no caregivers, and that's moderate and then severe for the patients without caregivers. Okay,
so I hope for the ones without caregivers, so many of them call somebody who's assisting them but might not be, like a live-in, like a spouse or whatever.
Mm-hmm.
They call them their backup brain. And they help them with bills, and they help them with organization and things like that. I hope that they are taken into consideration in terms of the support that they give, because they're out there helping people get their, legal documents in order, and just, trying to figure out adaptions and shortcuts, as the disease progresses.
And although I am not qualified to talk about how Medicare is going to, determine caregivers, but and this is not coming from a place of knowledge. It's an assumption that this is the case. I don't believe there's a requirement that it's a live-in. Mm-hmm. So I would say that those secondary brains, is that what you call them?
Backup brains.
Backup brains, great, yeah. Those backup brains should make themselves known as part of the application process so that they can be assessed to see if they qualify.
Okay. And it would be good for in the assessment, and I don't know if it's in there, but for the assessor to be able to use familiar terms, or do you have someone who helps you on occasion pulling some of those things out? Because, again, you're dealing with somebody with dementia, and well, like with all of us, we have our definitions of what a caregiver is.
Mm-hmm.
And a lot of them are very proud that they're doing stuff on their own, even though they're having assistance. So letting them know that the door is open to hearing that, because that would be a good data point, even if it's not addressed, to be able to collect for people on that. So my 2 cents on that.
Absolutely.
Well, let's talk about, what exactly will the guide provide? We kind of went over some higher level stuff, but like, as a family member, what could I expect you really helping me with?
Sure. So at the highest level, the primary provision of services to the family, the dyad, is a care navigator who is your connection to all of the care for the dementia patient.
That in itself is going to be huge and sweet and much appreciated, because it's a complicated maze.
Yeah. And so that care navigator has a number of responsibilities to provide these 9 services. And so that first service we've already talked about, and that was the comprehensive assessment.
Mm-hmm.
And so, that, as I said, it consists of the patient assessment,
Mm-hmm.
an assessment of the caregiver, but then there's also a home visit
Mm-hmm.
to assess the home itself, because we know that the home environment is potentially a cause for accidents and those kind of things, right? So all of those things are contributing to that assessment, which is then delivered to Medicare to determine eligibility. After Medicare says, yes, indeed, patient Marty is included and ready to participate and approved to participate, then the care navigator builds an individualized care plan specific to Marty.
Mm-hmm.
And that care plan must be signed off on. So first of all, before we get there, that comprehensive assessment has to be, and a dementia diagnosis, and that's why I said you've got to have a dementia diagnosis, has to be presented to a physician, and the physician says, yes, indeed, all the boxes are checked. The patient has been diagnosed with dementia. I believe that this patient is ready to be looked at by Medicare and approved for the program if they qualify. So a doctor has to sign off on the comprehensive assessment that's built by the care navigator. After the patient has been approved, then and that care plan is developed, then that doctor has to sign off on that care plan to say, yes, this care plan looks like it addresses the issues that Marty's having.
Okay.
All right.
One question I have before we go on is, from the time of the assessment to, Medicare approving this, any idea? Are we talking?
So they have committed. Okay. So there is no requirement on how much time takes place between when the patient or the caregiver inquires about the program and the assessment must be done. And I'm going to give you a little bit of detail on the background of that. As a guide participant, you are not allowed to say no to a patient who approaches you about participating in the program. If so, every one who says they want to be involved has to be given the comprehensive assessment, assuming they qualify. And that I told you about the pre-qualification. Do you are you actually in traditional Medicare, that kind of stuff. But once you pass that first assessment, you must be given the assessment, the comprehensive assessment. But there's no requirement on how quickly that must happen, because every organization has its own limits on how many of those they can get done, right?
Mm-hmm.
If as soon as a guide participant says, I don't have the ability to service Marty, at that point, they can no longer accept any new patients. So while I can't speak for other organizations, what I can tell you is how we're going to deal with that is when we are approached by a caregiver or a dementia patient, we will say, absolutely, we've got you on the list and we will get to you as quickly as you can. So that's the first source of delay. But hopefully, and frankly, what we have found is the delay at this point is not on our side. It's actually getting everything lined up with the patient and the caregiver to get that assessment underway. So, as you can imagine, caregivers are doing a lot of things and it's hard to get on their schedule. So, so that has been sort of the bottleneck for us.
Plus, there's a discomfort a lot of times with people coming into the house and people not sure I want to go there.
Well, and so thankfully the assessments can be done virtually. The in-house piece of this is done after the patient has been accepted into the program and the comprehensive care plan, individualized, personalized care plan has been developed. So we're already building a relationship at that point. So hopefully that assuages some of the concerns of the family about having someone come into the home, right? Mm-hmm. But to go back to your original question, so once we have finished the comprehensive assessment and the physician has signed off and says, yes, I believe that this patient will, potentially qualifies. I've done the pre-work to say, yes, the patient has dementia. Yes, all of the paperwork has been filled out, and they submit it to Medicare. Medicare has committed to us in the program contract that they will turn around those decisions in 45 days.
Okay.
And and then once they notify us that patient Marty has been attributed to Dr. Smith, we then are on the clock. And I think it's and I don't have the exact answer to this, but I believe we have to notify the patient within 45 days.
Okay. And
this is all stuff, and we talked about all the data requirements. We have to track all of that so that when we inevitably get audited by Medicare, we can show them that we were in compliance with all the guidelines.
Okay. So it could be up to potentially almost 3 months.
3 months, yeah.
Mm-hmm. For that. Okay.
Yeah.
Well, let's go on. So we've got the comprehensive assessment, we've got the care plan. Then what comes? What are the other points?
So, and I'm going to give it to you in the way that Medicare gave it to all of us, but in my mind, it's not logical the way they structured it. But the next care delivery service is a 24-hour, 7-day-a-week call service. So you either have to be able to talk with a care navigator or talk to a service that will then notify the the care navigator for follow-up. Okay. So that's a great resource for caregivers. because we know that often, it's not 2 o'clock on a Tuesday that these things happen. It's 12:30 a.m. on Saturday. So that's a huge benefit. What we believe one of the biggest benefits to the patient is the ongoing monitoring and support. And this is calls with the care navigator to understand how the patient is doing, calls to the caregiver to understand where are you struggling, how can we help, what education can we provide to help you be more effective in your role. And again, this is where there's a little bit of leeway in how this care delivery service is provided. We will be in contact with every one of our patients and caregivers at least once a month and more frequently if needed.
Okay. Well, that's good to know. And that ongoing support.
I believe the requirement for frequency of contact is, we talked about the 5 tiers.
Mm-hmm.
I believe it's related to those 5 tiers. I'm not certain on that. I think if you're in a low level with a caregiver, it's a minimum of quarterly that contact is made. Okay. If you're in a severe, it's got to be monthly.
Okay.
But our stated objective is once a month for everybody, at a minimum of once a month.
Okay, that's nice. That's nice. What else?
Okay, so the big one is, and this is one of the things that I'm dealing with right now, and that's care coordination and transition of care. So care coordination, many of these patients, in addition to having a primary care physician, will also have a neurologist. And the participation contract doesn't require, but it strongly suggests that the care navigator communicate with the primary care physician and any specialists. And again, this is another area that, there's a little bit of leeway. Our policy will be that we want to develop the best relationship with not only neurologists, but other specialists that the patient will have in addition to the primary care physician, because we believe that these comorbidities can accelerate the disease progression. And so we want to work with the patient on as many of their health conditions as we can, knowing that that's going to reduce the potential for the progression of dementia.
Well, the other thing that it's going to do is a lot of families are uncomfortable on how to communicate to the doctor, because they don't want to bring stuff up during the appointment, sometimes in front of the patient, though that information needs to get delivered. And not everybody, especially many of our older adults, they don't even have email. Many do, but it's just not comfortable. Everything's now, we'll just text here. We'll send it to you on the phone, and they're like, it's too small.
Use my app and look it up on your right.
Yeah.
Exactly.
So to be able to have a care navigator that could, it would probably be easier on the doctors too. Pull all of that together, get that information centralized so everybody's seeing the same thing, because there's nothing worse than, well, I didn't know that was happening over here. That's going to be a massively positive process, I think, to help everybody be on the same page. And it lifts the burden off the family of trying to figure out how to do that or when to do that, because what I hear from them all the time is, I don't have time. I don't want to get into the loop. I don't use a portal. Don't tell me to go to the portal,
Well, and as important, many caregivers aren't medical professionals.
Mhm.
So it's very difficult to have a conversation between a professional and a non-professional, because it's literally, you're speaking two different languages.
Yep.
And so that's a huge piece of the care navigation is having that medical professional in the loop who is able to talk, in a very short sentence, exactly what the issue is, because I'm using professional words that their primary care physician is going to know exactly what I'm saying, and they'll have a response.
Yep. And
Right?
it's not a story that's 2 pages long.
That's
And
exactly
then
right.
still reading it going, what was the question? Yeah.
Right. And more importantly, the non-professional may not even pick up on the actual issue that's there, right?
Oh, very true.
Because they're not trained to understand how that all works.
Yep.
So that's a huge value. The second half of that we just briefly touched on is the transition care. And that is, exactly what my mother's going through right now, which is when you are discharged from the hospital and you need to go to another facility, there's a lot of coordination that takes place. And having that care navigator involved in that process makes that go a lot smoother.
Yep. So let me ask you this. So let's say let's say we'll use your mom as an example. Let's say she goes to transitional care, but they realize, okay, she no longer can live independently. This just isn't, we're not getting her where we want her to go. Then does the program cease? She gets placed and then it's just.
Well, so I don't honestly know the answer to that question. My guess would be no. It is, so another piece of this is the referral coordination. So we are participating providers are supposed to have a list of resources available to guide the family. So where are respite centers? Where are facilities that could do more assisted living, right? So we have access to that, but we aren't required to actually get the placement done.
Okay. So just my 2 cents on that. I hope when that information is passed off to families, it's not just a name and a phone number and an address, but you have guided questions for them to ask, because they don't know what questions to ask to be able to protect their loved one, to be able to make sure the care is accurate. And it sounds silly from, do you have openings? Because if you don't have openings and you don't have a male or a female bed, whatever I need, I'm off to the next one, because you're under that crunch time. And families don't know that, and they'll stay on the phone because somebody else is trying to sell them a bed that's not existent. And so I really hope that there's something pulled together to help people through that, because I have dealt with so many families that just, I've been worried that the care partner is going to have a heart attack and all bets are going to be off during that process, because they have just, it's just overwhelming with what they're dealing with.
And I thought I was fairly well prepared for this. And, when we had a meeting with the care team a week ago Wednesday, and they said, well, unless your mom continues to make progress, we can't let her stay here. And I said, okay. And they said, well, we don't have any beds. And it was like, oh, well, I didn't even begin to contemplate the point. I figured once she was in for all stages, right?
Yep.
Well, no, it's all dependent upon what's going on. Now, thankfully, we've solved that problem because a bed has opened up, but you're right.
Yep. And it's like, you got 2 to 3 days to get it moved, or they threaten that they are going home and they know that they can't go home with them, but that threat is used, I can't tell you how many times, and it's horrible with the family because they know that they can't do that. Okay, well, let's go to number 5.
Sure. So this one goes, in conjunction with sort of that care coordination. There's a requirement for medication reconciliation and medication management. So the whole idea is to understand what's the current list of medications that the patient should be on, and making sure that they are actually have prescriptions for those meds. There's also some requirements, and one of our founding partners in the company is a career. He's a pharmacist, and there's a requirement that I don't know the details on, but we are also graded. The participating providers are graded on the patient's utilization of some very, very, I don't even know what the right word is because I'm not a pharmacist, but let's just call them very heavy medications that they want us to minimize and eliminate whenever is possible for dementia patients. So that is huge because, again, going back to that coordination of care between professionals, once we've got the approved list, we can then circulate that to the primary care physician, to the neurologist, so that they've got the latest information. And then as the primary care physician determines that changes are needed, we make sure that the lists are updated and get circulated.
And that's going to be so helpful because, again, I can't tell you how many families I've talked to that said, oh my gosh, they put somebody on this medication and it just blew up everything. I mean, the adverse reactions for some of them, I mean, were downright critical and threatening. I mean, they got aggressive, all kinds of stuff. But being able to have that review, and as we all know, some medications just don't mix well together. And some medications don't mix well with certain types of dementia as well. And so, and that's something families typically don't know until it was mixed. And then they found out there was an issue after the fact, which usually ends up in a hospitalization and sometimes being tossed into a geri psych unit, which we don't have enough of those either. So that's going to prevent a lot of problems, I think, with that.
That's correct.
Gosh, that's great. Okay, well, let's keep going because I think you said there were 9 of them.
Yeah, and I'm looking at my list and I see that, I think we've talked about all but the last 2. So somehow we got, but so now the last 2 are focused on the caregiver. And the first of them is caregiver education and support. So this isn't, as we've talked about this whole time, this isn't just specific to the patient. And that care navigator has a role to play with the caregiver as well. But there is a requirement that we provide, that every participating provider provide caregiver education on dementia. So that is going to be a huge, huge benefit because we all start out and knowing nothing. And so just the ability to have that available as a resource will be a godsend. The other piece of this that is our personal philosophy is that the caregiver is our biggest ally. And the more we can help them understand not only what to do, but the why to do it, that's critical. Because then they understand, oh, I understand why we're focusing on hydration. Because hydration is so critical, right? And so then they are stressing and accentuating the exact same things to mom or dad. It's really important, that you drink this glass of water because that's going to keep you from having, blood pressure issues, right? Which then turn into falls. And So that education and caregiver support is a huge one.
Oh,
And then
yeah.
the last one is the one that we've already talked about, which is, the respite care.
Hmm. Um, okay, so yeah, and that'll be great. I wanted to add on the caregiver education piece.
Yeah.
Approaching that from the whys is so critical. We have, you know, there's so much stigma around this disease, and we have been told for years and years and years, and it's started to change, but for years and years and years we have been told, if they don't know you, you don't need to show up. There's nothing you can do. And I know from my 30-year journey with my own mom, that is so far from the truth, it's not even funny. And understanding those whys to change our approach, will change our outcomes. And, really little things matter. For example, I'll just use the one of sundowning. It absolutely drives care partners crazy. Why are they following me? I can't even go to the bathroom, And I always explain it that you have to think that you've become their security blanket. You're like Charlie Brown's security blanket to them. You give them comfort. They're scared of this world. They don't understand it anymore. And just being able to think to yourself, gosh, how lucky am I to give somebody that much comfort, changes your reaction to that, to their reaction. I don't even like calling it a behavior, because when we call it a behavior, we're putting them down and we're telling them they're the problem. And they're just trying to communicate with us. They're just trying to feel safe in this world. So there's so many cool things that can be done to shift and to ease, how we look at things. I think that is going to be really well received, and I think the outcomes are going to be amazing with that. Now, one of the things that I had heard, and I don't know if this is true or not, but it was one of the things that excited me too about the program, was that physicians were going to be able to refer out to other programs. So if it's memory cafes or an art class or doing something with horses, I mean, there's just so much stuff out there that people don't know even exists. Is that part of this program? Would those be considered
So that
some
that
of the
would be
respite time things?
not I can't answer your question honestly. I think there's probably some requirements for what qualifies as respite that would be paid for, but I don't know enough about the details to even venture a guess. I can tell you that that's part of, one of the specific benefits, and this might be the one we missed, or I don't remember, is referral coordination. So the whole point is the care navigator is supposed to have a list of all sorts of services that they can refer the patients and the carers to. So, I don't know. Again, I don't know what the requirements are for how broad that list has to be. Again, our belief is that the more of those services that we have available, the more valuable that service becomes. So we intend to have fully fleshed out lists of all sorts of those resources. But as you say, if you don't know it exists, it really doesn't exist, right? And so I'm not sure I even understand all of the services that might be available.
Yeah. Well, and none of us are ever going to, know them all, because no one's really gathering them. I mean, our dementia map is doing that to an extent, but again, it's small compared to the mountain of services that are out there. But there's cool things from the choirs that people can participate in, to the memory cafes that are support groups for people with dementia and their care partners, which again gets them in a peer setting so they don't feel so alone. That is really powerful. To respite care, to online music therapists doing sessions. Many of these things are for free. Caregiver coaches on top of the care navigator, I don't know how much coaching they'll really be able to do with some things, because that in alone is a massive job, just connecting the
Yeah,
dots and keeping that going smooth. So yeah, there's so many neat things, and I hope that the guide is open to looking through all their data points at all these creative things to be able to help people feel engaged and feel part of the community, because nobody wants to be a diagnosis. They want to be a person that engages and has a social life and things. So
absolutely.
this has been wonderful. Now,
Before we part, I would be remiss if I didn't ask you a question, because you very briefly mentioned the dementia map, but I want you to go into a little bit more detail in case any of our listeners aren't familiar with that resource, because it's wonderful.
oh, thank you. Well, Dementia Map was always a vision of mine since day one. When I'm amazed that no one's pulled this together, but I wanted to have a place where it was free to access, that is useful for people with dementia. So it's simple for those living with dementia, as well as their care partners that are exhausted, both family and professional. I think sometimes we divide it up, like, as a professional I need this, and as a family member you need that, and it's like, no, we all need to know this type of information. And we have like 150 categories that people can search. There are products, services, and tools. There's a wonderful blog. There's glossary of terms, because we don't know what we don't know. And there's a calendar of events that it actually isn't built out near to what it once was. And I think a lot of it has to do from the feedback I'm getting from staff shortage, being able to get those things inputted. So we're looking at trying to do something a little bit different to connect people, because going to Google's scary. You don't know what is good and what isn't. We wanted something that was available on a global basis, because so much, even like our dementia friendly communities and memory cafes, those weren't US ideas. Those came from overseas. So we can inspire and share so much of what's going on and learn from one another, and let people have ease of access where they don't have to give any personal information. We're not collecting data points on the site. We just want to make sure people feel comfortable that they're not going to get hacked or scammed or bothered. We hear that over and over. And then I'll also plug Alzheimer's Speaks, which was my main site that I started back in 2009 when I stepped into this space. We have one whole section that is just free educational resources. So, they can find the radio show there. They can find Dementia Chats, which is something that I facilitate monthly with people living with dementia. And they tell us what it's like, what are their needs, what's working, what's not. We have Dementia in the Arts, where we interview people that showcase their artwork. And again, that's one of the things that has really resonated with me, because what we hear over and over from people doing all different types of art is when they're in the zone, their symptoms decline. And sometimes they just melt away. And yet we have this belief that they can't learn anything new. And you look at some of the artwork, some of these guys should be commissioned, and they never did art before their dementia. So, it's kind of a stigma buster. We have a section for poetry. People submit poems, because not everybody wants to go to a support group, but they can feel and they can see what someone's describing through a poem in private, and they can laugh, they can cry to themselves, because maybe they'll never be ready to go to a support group. So we try to have a lot of different resources, things, plus some tools that I've developed over the years that people can just download. And we're always looking at, new ways to connect. But again, everything on there is free, because I know people just can't afford all this stuff, but they need access to it and they deserve it. So thanks for asking on that. I appreciate it.
You're very welcome.
Now, you had also given me where people can find more information to find guide providers. So I'm just going to put that in the show notes for everyone to be able to
That's perfect.
find. I
I
really appreciate your time.
No problem. I have one more interesting news bit. So I unfortunately I don't have all of the details yet, but I guess two things. So Medicare committed to notifying every traditional Medicare patient in the country who has been identified as potential dementia through care that's been provided by their neurologist or primary care physician, with a letter saying these are the guide participating providers that are supporting your zip code. And therefore not making a suggestion that company A is better than company B or anything like that. But that is, those, we don't know when those letters are going to go out, but they had initially said that it would have been later this fall, but I think they have rolled that back into 2005 to 2025, because obviously then the new programs will be coming online later that summer. So that's number one. But number two, just this week we were asked by Medicare to provide the URL of the participating provider to them, because they are going to publish a directory of all of the websites of the participating providers. I don't know when that is going to be published, but the requirement was that you had to have your website into them by midnight on this coming Monday. So that's going to be another resource. Unfortunately, I can't tell you where that is. But for those of you who can't find the link that Lori's going to put in the show notes, you can just go to cms.gov. That's the Center for Medicare Services, cms.gov, government. And if you type in the search bar, the little looking glass, magnifying glass, if you just type guide, you will get to the guide section, which is where this link will also take you. So there's an article there that has a link in it that will download a spreadsheet of all 390 some of the approved participating providers, and it will tell you, are they established, meaning they can treat patients now, or are they new, which means that they can start treating patients next July.
Okay, well, that's wonderful because, like I said, when I first heard about this, everyone I talked to, no one knew anything about this, and so I've been really trying to elevate this and get this out there, and it is important for people to understand that, okay, there's 90 some providers. That's for the whole US. So there might not be anybody in your area. Let me ask you this though. Is it possible to do some of these services just via telehealth? I know like the assessment they had to do in home.
Yes, the home.
But is there something that is modified out there to be able to reach more people at all?
All of these services are designed and are approved to be delivered via telehealth.
Okay.
So that's the real power of this. So, without going into the arcane details, when COVID came down, there were a number of healthcare services that were authorized to be provided by healthcare via an emergency act. And that act expires on January 1st of next year. And so there's a lot of care services that are going to have to go back to in-person visits. But Guide was specifically designed so that all of the services could be delivered via healthcare. Now, just a personal anecdote. One of the patients that we are working with to get them into the program, the caregiver said, I don't think a telehealth visit will be effective for my husband. So we are going to meet the caregiver and the patient at the primary care physician's office in order to do the dementia assessment.
Okay.
So obviously there may be some need for in-person stuff, but the program was designed to be fully deliverable via telehealth.
Okay. And I would think even with the home assessments that you would be able to hire somebody to do that.
Yes, and so that's so the way we're handling that is we are working with third-party providers, which we have to have a contract with and notify Medicare of that relationship. But we are doing that with a third-party home assessment company.
Okay. Well, wonderful. Again, you can go to Marty's website, which is embracepreventioncare.com, embracepreventioncare.com. And if you do a / dementia care, you'll get right to this. You can email them at info@embracepreventioncare.com, or you can call and talk to them at 302-329-8452. And again, we'll have all this in the show notes, along with the cms.gov that you can search for, and the long link as well for people to be able to go directly to. For our listeners, I just want to say thank you so much. Please be a giver of hope. Join Alzheimer's Speaks and help pass the word of information. You don't know who is in your sphere of influence that needs this information, because this is an uncomfortable conversation and a lot of people aren't ready to have it, but they see your feeds and they will reach out when they're ready. And I think this is great information. Also, this is something that can help families go in and ask their doctors, hey, do you know about the GUIDE program? Because a lot of dementia families are educating their physicians on resources that are available. And this is just another one for them to gain knowledge of, in case they're not aware of it. Their time is limited as well. So
that is a very great point, because I can tell you from personal experience that the vast majority of physicians, even neurologists and dementia specialists who you would believe should know about this, have no idea. Yep. Now, the really gratifying thing is that when I talk to them about this program, physicians say, oh, this sounds like something I definitely want to refer my patients to, because I know that this will be helpful for them. And we are also seeing dementia experts who are saying, hey, how can I participate? Because this would be vital for my patients.
Exactly.
So don't be surprised if you go to your physician and you know more about the GUIDE program than they do, because unfortunately it's a well-kept secret right now. But we're hopeful that through the great efforts of Lori publicizing this, that we're going to get the word out, because this is truly a great resource for people living with dementia and the people that love them.
Exactly. And again, I think getting this information out to the doctor's office will change how they give a diagnosis, because so many doctors, and we've talked to many, there's been studies on it, and there was a study not too many years ago that said a lot of them weren't even passing on the diagnosis because there was nothing they felt they could do to help the family. And this is setting up a whole different page and shining a light, and hopefully getting people to understand, nobody wants any diagnosis, but it's not going away just because you don't want it. And there is help out there. There's a ton of it. And we just want to connect you to to the right things to get rid of your pain points so you can get on living life and having a quality life and building on the relationships that you have. So again, Marty, thank you so much. Appreciate your time today.
You're very welcome, and thank you for having me.
And we'll have you back for an update maybe in a year or something, or if there's more
Sounds
things
great.
that happen on how is this being received and tweaks and changes, all of that kind of stuff too. So thank you.
You're very welcome.
Bye, everyone.